Assalamu alaikum. This is an updated overview on vocal fold nodules or singer's nodules. In this overview, we shall go through things like phono microtrauma and try and answer questions on whether vocal nodules are genetically predisposed to, and elaborate on the basement membrane zone, the suggested site of origin for the vocal fold nodules, and show examples of vocal nodules not originating in the midmembranous part of the vocal folds and when, and cover on prenodules, small nodules on the undersurface of the vocal folds, soft nodules in the juvenile type, and how to differentiate between soft nodules and mature nodules. We'll also cover the bamboo nodes type of nodules from autoimmune disease that may resemble vocal fold nodules, discuss the conservative management of the nodules, which is the gold standard, and also show clips of microlaryngosurgery or laser excision in selected cases, and discuss the risks of recurrences. Vocal fold nodules are benign nodular swellings on the medial edge of the vocal fold covering epithelium. They are tiny, usually less than 3 millimeters in diameter, and they are classically located at the junction of the anterior and the middle thirds of the vocal folds, that is to say, the mid part of the membranous vocal folds. This is presumably the site of maximum excursion and forceful contacts between the vocal folds during phonation, and is the site for maximum phonotrauma. There is usually a history of vocal abuse and high professional vocal demand. Nodules, age and gender. Nodules are commonly seen in children, adolescents, and middle-aged females. In the pediatric group, the incidence is higher in boys. On the other hand, in adults, they are much more frequently seen in females. This is related to the higher fundamental frequency of vocal fold oscillations. The higher frequency of the vocal fold oscillation determines the absolute acceleration and deceleration forces, and when these are increased, they would also be increased in children and the female speakers. Nodules would disappear spontaneously in boys with the natural reduction in the fundamental frequency after puberty, but the females' nodules in adolescent and children would persist into early adulthood, and they are very much more commonly seen in females, particularly under the age of 30. While the exact incidence and prevalence of nodules in the general population is not known, it is known that 25% of children with dysphonia would have vocal fold nodules, and about 6% of adults with voice problems would also have vocal fold nodules. A higher percentage would be expected in professional voice users like teachers and singers. There is a wide agreement that the etiology of vocal fold nodules has something to do with phonatory strain, phonomicrotrauma. There is also a traditional suggestion that this is more due to voice abuse than voice overuse. The following are examples of the causes of vocal fold nodules, including forced voice production, talking for a prolonged period of time in a loud voice, often above a background noise, and repeated shouting and screaming, and or singing above one's natural range. Occasionally, things like repeated coughing and throat clearing could also add to the injury of the vocal folds. The background would be psychological factors or personality traits. Extroverts are more prone to developing nodules than their introverts counterpart. Upper respiratory tract infections and chest infections with allergies and laryngopharyngeal reflux can all contribute to vocal fold congestion and development of nodules in the long run. The impact of the vocal folds on each other with repeated trauma at the mid-membranous part for prolonged periods would lead to localized swelling and epithelial thickening, and from here nodules would start. Whether vocal fold nodules development is genetically predisposed to or not is not clearly known. We have two pieces of evidence. One is that there is a strong association between the development of vocal fold nodules and having microwebs at the anterior commissure in almost 1 in 4 cases. The association with microwebs will generally tell that these nodules would be refractory to conservative therapy. The second piece of evidence is that immunohistochemical studies had showed that a certain glycoprotein, the fibronectin, present in the extracellular matrix in the superficial part of the lamina propria of patients suffering from nodules are actually increased. Whether this is a predisposition to nodules or an association with phonotrauma is not yet settled, but the hypothesis is some individuals may be genetically predisposed to the development of nodules because they have higher concentration of this glycoprotein in their extracellular fluid in the superficial part of the lamina propria. This is a cross-section of the vocal folds showing the 5 layers, starting with the covering epithelium, which is anchored to the superficial fluid part of the lamina propria, followed by the intermediate elastic part of the lamina propria and the deeper collagenous part of it. And finally, the core of the vocal fold is formed of the muscle part of the thyroarytenoides, the vocalis muscle. The epithelial cover of the lamina is anchored to the superficial part of the lamina propria by a basement membrane zone. This is in its part formed of 2 layers. One of them, the more superficial, is the lamina lucida, which is low in density and lies next to the basal epithelial cells, followed more deeply by the lamina densa, which has type 4 collagen fibers anchoring the epithelium to the superficial layer of the lamina propria. This is an area that is subjected to high levels of stress and shearing forces. Imagine that this area would be subjected to few hundreds of times to movement during oscillation, and all these forces and shearing effect could cause injury to the epithelium and the underlying superficial layer. The basement membrane zone functions are basically to attach the epithelium to the superficial layer by collagen fibers, and also it is helpful and essential in the repair and the maintenance of the epithelium if it is subjected to any injury. Over time, with chronic disruption of this layer, this may lead to the formation of vocal fold nodules. Vocal fold nodules needs time to develop. They pass through various stages of development over a period of time. It starts with repeated collision at the mid-membranous portion of the vocal folds, leads to localized vascular congestion and edema at the site of maximum phonotrauma. The increased trauma and tension would also disrupt and hyalinize the superficial part of the lamina propria and cause injury to the basement membrane zone. This would lead to epithelial attempts at repair with hyperplasia and thickening of the basement membrane and increased deposition of type 4 collagen and the fibronectin. If this continues for a certain time of repeated injury, the early nodules would have progressively more thickening, more deposition of type 4 collagen, fibrosis, and the callus formation. So the stages again are phonotrauma in this segment because of the excessive stress on the mid-membranous part of the vocal folds, causing injury to the superficial layer of the lamina propria and the epithelium, followed by tissue remodeling and scarring, resulting in the development of the tiny nodules. Abnormal vibratory pattern are more injurious and damaging than high-intensity vibration, and this would explain the higher incidence of nodules in singers who are untrained compared to formally trained performing artists. And histologically, this is manifested as epithelial hyperplasia with thickening of the covering epithelium, thickening of the basement membrane zone, hyalinization and edema, and abundant fibrin and organized collagen in the basement membrane and the superficial part of the lamina propria. This is generally acellular, and immunohistochemical studies would confirm that the thickened basement membrane zone would be rich in fibronectin. Cases with vocal fold nodules present clinically because of their voice problems. The principal defect would be reduced vocal fold oscillation. This is due in part to the increased stiffness of the vocal folds, but also may be due to a mass effect if the nodules are big. There is also an element of incomplete closure of the vocal folds during phonation, given this hourglass appearance. This is characteristic. This would lead to a voice that is husky and breathy, and also to voice fatigue when their symptoms worsen on prolonged voice use. This is sometimes associated with tenderness in the neck around the larynx, some discomfort in the neck or throat during phonation. The voice would also be deeper in pitch, and sometimes there may be voice breaks, particularly at the higher end of the range of the voice. In singers, it may start with the singers complaining of inability to reach or sustain the higher notes of their range, and later they may develop pitch break and also voice fatigue. And then the clinical examination. There is always a history of voice abuse or overuse. The laryngeal examination may show the classic picture of bilateral symmetrical vocal fold nodules in their mid-membranous vocal fold position, but it may also show a variety of other shapes, locations, size, and symmetries of the vocal nodules. It does not have to be always in the mid-membranous portion of the vocal folds. In some subjects, you may even have multiple nodules, and you would see the mucus strands across these pairs of nodules. This is a variety that is not usual, but it can be seen. You may also notice asymmetry in the shape of the nodules. One side would be bigger than the other, or one side would be more pointed and the other would be flatter. Or you may even see the pair of nodules in a different position, a bit more anterior. This is typically seen more in singers, particularly in sopranos, who use higher frequencies to produce the singing voice, and this would be the site of the maximal phonotrauma. And of course, sometimes there may be differences in the color of the nodules itself. It may be paler or a little bit more congested if it is early in its early stages. The nodules would prevent complete adduction during phonation, leaving a bit of a glottal opening. The typical configuration of this glottal opening during phonation is the hourglass appearance, with two areas of glottal opening, one anterior and one posterior to the mid-membranous portion of the vocal fold. But there are also variations in this configuration. You may have only a posterior chink, you may have a completely longitudinal chink, or you can have a posterior chink or even an anterior chink. The vocal fold nodules may be keratinized and with a shiny layer on the outside of it. They may be pinpoint, or they may be a little bit more fusiform in shape. Soft nodules have a much better prognosis than hard nodules. Soft nodules respond much better to voice therapy and rarely require any surgical interventions. Soft nodules would be seen as fusiform nodules with a wider base and the appearance of edema fluid inside the nodule. Juvenile type of nodules are usually soft nodules. They have the fusiform shape and they give the appearance of having edema fluid inside. In boys, they respond very well to voice therapy and may resolve spontaneously with puberty, with the reduction in the vocal fold oscillation rate and the change in the size of the larynx. The juvenile type in girls may persist into adult life. Video stroboscopy or high-speed camera photoglottography would provide valuable information to differentiate between vocal fold nodules from other vocal fold lesions like polyps or cysts. Generally speaking, the mucosal wave are not disrupted in vocal fold nodules, whereas it would be expected to be abnormal in cases of involvement of deeper layers of the vocal fold, like in cysts, for example. It can also be useful to differentiate between the different subtypes of the nodules. May show higher keratin, or it may show more edema, to differentiate between the soft and the hard nodules, and provide information about whether they are more likely or not to respond to the voice therapy. In Singer's nodules, the nodules are usually a bit more anterior in position, not in the usual mid-membranous portion, due to the high-pitched singing, particularly in sopranos, with preferential vibration of the anterior portions of the vocal fold. This is where you would expect the phonotrauma to happen. The nodules are also usually smaller in size and more prominent and white in color, reflecting a more superficial response to the phonotrauma. Prenodules, or a nodular diathesis, refers to very subtle changes at the vocal fold edges, so subtle that the lesion is not called a nodule yet. They appear as a mucus collection in the presumed site of the nodule, and there is scant evidence of any mass or stiffness of the coat apart from collection of mucus in there. And there is also an incomplete closure of the glottis during phonation, giving the hourglass appearance. Stroboscopy may not show any changes in the vibratory amplitude or the mucosal wave, but on soft phonation there may be a reduction in the vibratory amplitude and the mucosal wave. The mucus, you could see the collection may swirl around the rough area where the nodule is going to start and form a turbulent collection. When nodules start to develop, they may be so small and on the undersurface of the vocal fold edge that they may not be seen easily. They may not be visible on the upper surface of the vocal fold. Sometimes only during the glottal cycle, when the lower lips of the vocal fold edge meet first in the midline, these tiny nodules can be seen. When the upper lips of the vocal fold edge meet in the midline, they will obscure the tiny nodule. A loud phonation can be used, and this would accentuate the difference between the lower and the upper lips of the vocal fold edge movement, and with stroboscopy or high-speed cameras, you can freeze at the when the lower edge meet and see a very tiny nodule on the undersurface of the vocal fold. And then early nodules would form, are fusiform in shape and have an appearance of having fluid inside like edema. These are the early soft vocal fold nodules that they respond much better to voice therapy, and rarely surgery is indicated. And then chronic and mature, firm and fibrotic vocal fold nodules would develop. They would have a different appearance, less fusiform in shape, more pointed or circular in shape, They have bigger size and bigger mass, and the changes in the vocal fold dynamics would not be only due to the stiffness but also to the mass effect of the thickened vocal fold nodules. There may be a non-vibratory segment with poor prognosis, and these are the type of nodules that may not respond to voice therapy well, and surgery would have to be considered. The vibratory amplitude and the mucosal wave may be absent over these types of nodules due to the attachment of the nodules to the thickened basement membrane zone. These are the hard and mature vocal fold lesions in action, with evidence of mass effect in addition to the stiffness of the vocal fold edges, and the nodules may be seen to rock back and forth in the vibratory cycle. There may still be a symmetric reduction in the vibratory amplitude and the mucosal wave. Differentiation between a hard versus a soft vocal nodules is useful in assessing the prognosis, the likelihood of response to voice therapy alone, and on deciding whether surgery is required or not. Hard nodules on steady phonation will appear to have a rocking movement separate from the mucosal wave of the vocal fold margins due to the mass effect on top of the stiffening effect on the vocal fold edge. The hard nodules will have a greater reduction in the amplitude of the mucosal wave. In patients with hard vocal fold nodules, the mucosal wave will propagate sometimes around rather than across the vocal fold nodules. They may also have a hyperkeratotic appearance, like in this. And lastly, hard nodules will have a more apparent hourglass appearance than in soft nodules. Occasionally, it may be difficult to differentiate between a vocal fold polyp and a reaction on the contralateral site from bilateral vocal fold nodules. The nodules are usually have a sessile base and usually much more symmetrical than a polyp, and a reaction on the other side. In the preferred site, the mid-membranous part of the vocal fold, and nodules would have less interference with the mucosal wave and its amplitude. Autoimmune disorders can affect the larynx in various ways. They can, for example, cause a cricoarytenoid joint fixation, or mucus inflammation, or subglottic stenosis, vasculitis, laryngeal edema, or vocal fold paralysis. They can also produce lesions that may resemble vocal fold nodules very much, like the rheumatoid nodules or the bamboo nodes. Examples of the autoimmune conditions that may produce these bamboo nodes are the rheumatoid arthritis, the systemic lupus, Sjogren's syndrome, Hashimoto thyroiditis, and systemic sclerosis. These bamboo nodes are pale yellowish lesions in the middle third of the vocal folds. The patients would usually have a blood test that is positive to autoimmune disorders with elevated ESR, positive rheumatoid factors or Sjogren's antibodies, or an elevated antinuclear antibody levels, or hypergammaglobulinemia. These bamboo nodes, called bamboo nodes because of their resemblance to a bamboo plant stem, would be treated much in the same way like vocal fold nodules, with conservative therapy based on voice hygiene and voice therapy. But in addition, systemic steroid may be helpful, but if it's necessary for long-term treatment, injection of steroids could also be useful in the vocal fold nodes, but shouldn't be given more than 3 times a year so as not to develop any atrophy of the vocal fold tissues. Some very resistant cases may require surgical excision. And beside these rheumatoid nodules or the bamboo nodes, there may be other asymmetric or irregular or suspected features of lesions that may resemble vocal fold nodules, but with required a high level of suspicion. They may require to be treated promptly because some of these could have keratotic changes on the surface. These may resemble early dysplasia, or they can have these very congested margins around the pale lesion. This can be a tiny tumor in an ectopic minor salivary gland in this case. Management of the vocal fold nodules. A Cochrane review previously concluded that there were a little evidence to base reliable conclusions upon about the comparative effectiveness of surgery against non-surgical intervention for the nodules. We know that vocal fold nodules may settle spontaneously, particularly in boys after their puberty. And once the demand on the voice, the extra demand returns to normal. If the nodules are not causing significant voice problems, the general advice is that they should be left alone. They should be treated conservatively. And the first thing is that contributory factors such as reflux or allergy of the upper respiratory tract should be appropriately treated. Also, any psychological issues should be addressed. And the primary treatment of vocal fold nodules is voice therapy, starting with vocal hygiene. This should be tailor-made according to the individual needs of each patient. And the first step would be to eliminate the behavior aggravating the phonotrauma and correct any maladaptive reactions or practices to such aggravating factors. Vocal education, educating the patient about their pattern of phonotrauma, would enhance the compliance to the treatment. Patients will be educated to phonate in a healthy laryngeal environment in order to optimize their voice quality. In addition, voice therapy would entail direct exercises, specific exercises to correct the undue phonotrauma, and these are designed to achieve a balance between the pulmonary support and the vibratory phonatory forces. These exercises will be based on the nature of the vocal fold nodule and the pattern of the vocal usage of a particular patient, and involves things like postural correction, relaxation on release muscular exercises for the chest and the neck and the larynx, and breathing exercises. Voice therapy can be successful in as much as 90% of the cases, and even if the vocal fold nodules persist, sometimes the voice functions improves without complete resolution of the nodes if there is a form of irreversible changes in the basement membrane zone area. But in a very small number of patients, surgery may have to be considered. This should virtually never be performed without adequate trial of expert voice therapy. But if the symptoms and the vocal fold nodules itself is refractory to maximal and compliant voice therapy, this is one indication for considering surgery. Also, mature nodules that may be better managed by surgery rather than prolonged voice therapy, or nodules that have atypical features such as asymmetric nodules, irregular nodules, or suspected features. When a decision is made for surgery, microlaryngosurgery with excision of the nodules should aim at preserving the normal mucosa and keeping a straight vibratory edge, a straight vocal fold edge, and adequate glottic closure with minimal resection and raw surface on the vocal fold surface are very important. It's also important not to expose or damage the intermediate layer of the lamina propria. The initial success rate after surgery may be up to 95% of the cases, but recurrences within 5 years follow-up or so may be as high as 19% if the patient reverts to the old vocal use, abuse or misuse. The outcome of laser resection is comparable to cold steel surgery, and it is the surgeon's choice to select the modality of the surgical intervention. On microlaryngosurgery, it should be remembered that the superficial layer of the lamina propria may be thinned and scarred. The center of the vocal fold nodule is grasped with a non-traumatizing forceps and pulled medially, and then a straight incision is made on the vocal fold epithelial cover, and curved scissors are used to minimize the chances of secondary notching and to minimize the amount of excised epithelium. The two vocal folds can be dealt with in the same fashion at the same setting, but if the nodules are very anterior, care must be taken to prevent any raw surface close to the anterior commissure. Laser microsurgery may be used with jet ventilation, curved 1.5 mm beam length incisions, 1 mm penetration with a 10 watt power, single pulse mode, and a pulse duration of 0.05 seconds. This will ensure minimal damage to the vocal ligament and minimal excision of the vocal fold mucosa. And then a plagette soaked with adrenaline would be used to clean the area, and the second side would be done in the same way with curved incisions and single pulse mode. Again, minimal amount of resection and minimal amount of heat dissipation to the lamina propria. And then injection with steroids would be helpful to decrease the inflammatory process and the scarring of the site of the surgery and decrease any recurrence. And a proper post-operative voice therapy is essential in maintaining a healthy phonatory behavior and minimizing recurrences. When the recurrent cases were analyzed, more than half of the recurrent cases did not have a proper post-operative voice therapy. Among the recurrent cases, less than a fourth of the patients only had post-operative therapy, in a study of a median follow-up period of 9.5 years. It was also found that patients who are treated with an integrated approach team, including surgeons and phoniatricians and speech therapists, had greater chances of a better outcome compared to those who underwent isolated voice therapy after surgery or underwent surgery alone. Recurrences of the nodules after surgery would be possible if the patient did not have proper behavioral therapy before the operation to address the phonotrauma. If the lesion is due to chronic phonotrauma, surgeons should have a frank discussion with the patient before the surgery about the risk of the recurrence, and in some cases it may be better not to proceed with surgery if there is a very little chance that the patient's phonatory behavior is going to change. By this, we come to the end of this presentation on vocal fold nodules. Assalamu alaikum.